Hello, my name is Oliver Frenzel, and I will present a video abstract in collaboration with my fellow OneRx team members titled Examining Attitudes and Beliefs that Inhibit Pharmacist Implementation of OneRx. We'll start off with an introduction to OneRx. OneRx is a pharmacy-centered opioid risk screening program. And the mission and goal of the OneRx is to assist pharmacists in identifying patients who are at risk of opioid overdose and/or opioid misuse. And the process follows in that when patients present an opioid prescription to the pharmacist then asks the patient to complete a risk screening tool. And this risk screening tool then stratifies patients to either a low, a moderate, or a high risk to adverse opioid outcomes while using the prescription opioid. And a focused approach then by the pharmacist is conducted to provide patients with education, support, knowledge, and skills for opioid harm reduction. The OneRx team recognized that pharmacists serve an integral role as healthcare providers in the community, and that's why OneRx was a pharmacy-centered initiative to delivering this instrumental care to their patients. Roughly 40% of pharmacies that enrolled in the OneRx program struggled to actively implement this. So the adoption and implementation of OneRx has been slow and associated with variability. And there's been limited research that's been dedicated to understanding barriers to implementation of pharmacy-centered programs. This leads us to our objective in this research, is to determine what attitudes and beliefs contribute to the unsuccessful implementation of the OneRx program. And to do this, we used a theoretical framework. And the theoretical framework we used is the theory of planned behavior. The theory of planned behavior has emerged as an influential framework for the study of human action. And it was originally developed and tested within the context of social psychology. But more recently, it's been adopted by healthcare researchers. And it is comprised of three constructs: attitude, subjective norm, and perceived behavioral control. Attitude refers to how favorable or unfavorable of an assessment the behavior in question is. Subjective norm refers to the social cues or social pressure to perform or not to perform the behavior from individuals that they work with or individuals they work for. And perceived behavioral control refers to the ease or the difficulty in actually performing the behavior, also closely related to confidence or self-efficacy, and the self-efficacy in the performance of future behaviors. These three constructs then lead to behavioral intention and resulting behavioral action. The methods for this examination included the development and distribution of a 17-item survey that was sent to the pharmacist in charge of each non-active OneRx pharmacy. And the survey questions were divided into three theory of planned behavior constructs: the attitude, subjective norm, and perceived behavioral control. Each question was answered with a 5-point Likert scale. And there were 17 surveys that were completed and returned that could be analyzed with a response rate of 74%. The next few slides will cover the results from the completed surveys. The first are the attitude constructs. And the attitude of the pharmacists were extremely positive. Medication safety and therapy recommendations are crucial to patient health outcomes. 100% of pharmacists agreed with that. Pharmacists feeling that the opioid crisis should be a top priority in our state, and 94% agreed with that statement. Pharmacists participating in opioid harm reduction as an important step to reducing opioid misuse, 94% positive. The fourth line item, or the fourth question, my patients will trust me more if I provide OneRx services. This was met with a split responses, about a third agreeing, a third being neutral, and a third disagreeing with that statement. And lastly, opioid risk screening allows the pharmacist to provide an elevated level of care. Vast majority of pharmacists agreed with that. Our third construct, the subjective norm, which is also the social cue or social pressure. The first question and responses are other pharmacies I'm familiar with and tend to participate in the OneRx project. We had 65%, a majority responding neutral. This may indicate that pharmacists may not completely understand or know what other interventions or practices other pharmacies are doing in the region. The following three questions, my pharmacy staff would support the use of opioid risk screening. Patients and public health advocates would like to see me promote opioid harm reduction in my community. And lastly, would physicians approve of me using the OneRx and providing opioid risk screenings to patients? And all of those, a majority of pharmacists agreed with those statements. On our third section of the questionnaire, perceived behavioral control, the first question, I have the necessary support staff to participate in OneRx screening. Roughly 50% agreed with that, with the other 50% either neutral or disagreeing with that statement. Offering the opioid risk survey and recommendations would be difficult. Nearly 60% of pharmacists agreed with that statement, that it would be difficult to offer the risk screening to patients. The third item, workflow of the pharmacy doesn't allow for additional time spent with the opioid risk tool. Equal responses between agree, neutral, and disagree, with roughly a third of the pharmacists responding to each one of those responses. The next item, I have the necessary knowledge and skill to provide OneRx services. A vast majority agreed with that statement. Having significant control in determining what interventions my pharmacy participates in. Having autonomy during the decision-making process and the practices that are implemented. 70% agreed with that statement. And the last item, successfully integrating new interventions in my pharmacy has been difficult in the past. And this is indicative of past behavior, then influencing future behavior or future self-efficacy. And over half of the pharmacists agreed that past interventions have been difficult to implement. To summarize the results that we had just covered, the attitude section reflected a very positive disposition in enrolling for OneRx and the position of the pharmacist to intervene with opioid harm reduction strategies for patients. The subjective norm also was very positive in the fact that pharmacists felt fellow healthcare providers, nurses, physicians, etc., would support the use of OneRx risk screening in the pharmacy. Our last section, perceived behavioral control responses, had mixed positive and negative results from the questionnaire. A majority of pharmacists felt like they retained necessary support staff for OneRx. They had adequate knowledge and skills in delivering the OneRx process, and they have significant control over the interventions that are implemented in their pharmacy. However, negative perceptions, which were certainly the highest amount of negative perceptions were in the perceived behavioral control construct, included difficulty in offering the risk screening to patients, time constraints, and difficult experiences in the past. So past challenges and obstacles they felt then may relay on to present challenges and obstacles with another new intervention being initiated in the pharmacy. In conclusion, the theory of planned behavior was useful for identifying areas in which barriers or obstacles are the most influential to pharmacists during the implementation of the OneRx program. These findings may improve the future direction of education, future support mechanisms, and additional resources that form the foundation to improve the successful adoption and implementation of new pharmacy practices, for example, the OneRx program. Thank you for the opportunity to present this video abstract on behalf of myself and my OneRx team colleagues.